Welcome, everyone.
Right. Welcome and thank you for joining us tonight for the Ithaca College Occupational Therapy Alumni Speaker Series. Some of you may know me. I'm Mindy Casalino, the acting chair, which means I'm covering for Julie Dorsey. Right, I know. Right, I have a great team of support around me, but I think back in the summer, I'll be heading back into grad chair. So I'm currently the acting chair. Sorry about that. So anyway, this series is an example of how the Ithaca College Occupational Therapy experience will prepare all of you for a meaningful career by giving you a foundation for lifelong learning. It will inevitably prepare you for all the twists and turns that your career will take as time goes on. And I see alumni and new students, and I don't know, this is very exciting for those of us who have been here a while to see all these names pop up. Our alums are our ambassadors. They make us so very proud with all the work that they do, and they continue to engage with us in meaningful ways. The speaker series was born out of the vision of they were two amazing juniors at the time, and now they are grad students. And sadly, this is their final hosting event, but this was their brainchild, Emma Robinson and Julie Gainbarg, in the fall semester of their junior year, which was the COVID year, the first COVID year. And they were searching for a way to engage with alumni in more meaningful ways. They were really wanted to see, what does the OT world actually look like when we're out there working. So they approached Dr. Jenna Heffron to begin this entire series. And here we are almost 3 years later. So I commend them both. And our department and all of us are richer for this entire experience. So I'm going to now turn it over to Dr. Heffron, who will then introduce the moderators, who will then introduce our speaker for tonight. Thank you.
Yeah, thank you, Mindy, for that lovely introduction. And I just want to chime in as well. I'll usually let the chair do the intro and then hand it right over to the moderators, but I can't not say something tonight for, again, Emma and Julia's last event and time leading this series. So Emma and Julia, I'm just going to speak to you for a moment. The love, the care, and the, oh my gosh, work, the hard labor, real labor that you put into this, into envisioning the speaker series and into creating this opportunity for our community over the last 3 years is truly, truly incredible. So as you know, right, you created this during a very difficult time for everyone, for our communities, in your own lives, for the world, really, right? And you created this thing that has blossomed into what it is today. And I truly foresee that it's only going to grow and continue to blossom from here. So you helped bring our community together in the most difficult of circumstances and quite literally created something beautiful where there once was nothing. So you're both really, I mean this from the bottom of my heart, you're the epitome of visionary thinkers and change makers, and I can't wait to see what you do next. So the speaker series will always have been born from your imaginations and your hard work, and our community thanks you from the bottom of all of our collective hearts. So I see this truly as just the beginning, and really, really am forever grateful for your work, Emma and Julia. And also, right, our chair, Julie Dorsey, is of course on sabbatical, but this was something when Emma and Julia brought it to me, I brought it immediately to the visionary Julie Dorsey, right, who pulled in this idea of bringing in our alumni and establishing that network and broadening our community. So kudos and thank you to Julie too. And I also just want to mention, Emma and Julia have been working hard behind the scenes to bring in the next round of student moderators. So we will have Lauren Rodriguez and Axa Roy, who are both undergraduate students taking the reins from Julia and Emma. So they'll be joining us tonight and hanging on after the discussion to be prepared for our March conversation and moving on from there. So a really beautiful team that has brought all of this together. So wanted to share that with y'all. So without further ado, thank you, Emma, Julia. I'll turn it over to Emma this evening, who is going to moderate our discussion.
Yes. Hi, everyone. Thank you for the kind words. You're so sweet, and I could get all ushy-gushy and tell you all the ways you all mean so much to me, but I'll just say thank you. And I appreciate you all, and you all for being here tonight too. If you come to every speaker series or only one, or have watched on recorded videos, it means the world, and we're so glad that we were able to make something that's meaningful to us all in so many different ways, whatever that might be for you. So thank you all for being here. And I personally am so excited that the last one that Julia and I get to really host and collaborate on is Rachel's. We are both so excited for tonight's discussion. We think it's going to be absolutely amazing. But before we get into that, I will start us off with some access info. So if you look at the bottom of your screen on the command bar, you'll see a button sort of to the right of center called Show Captions. And there's a square that says CC in it. If you click on that, Show Captions, captions would pop up. And then if you click the little upward facing caret in the top right corner, aka Karen, a menu will come up and you can click View Full Transcript, and a full transcript will pop up on the side of the screen for you. You can click the minimize button, which is the little square in the top right corner, and you can pop that out and move that around the screen if you'd like to watch the screen and the transcript at the same time. And then you can just click on any of those buttons again, and the transcript or the closed captions would turn off. So please feel free to use that or not, whatever is most comfortable for you. And throughout any time, you can use the chat in the presentation. That's also at the bottom of your Zoom window. And similarly, you can click the minimize button and pop that out and move that around the screen. So use the technology in whatever way feels most comfortable for you. Audio, video, chat, whichever way will enable you to get the most out of this presentation. This session is going to be recorded along with a full edited transcript and posted to our YouTube site after this speaker series, so you can always go back and reference it for future use. But tonight is our tonight is part of our third annual speaker series, and we have the pleasure of hearing from our alum Rachel Mecalianos. Rachel is from Long Island and is currently living in Barcelona, Spain now. She graduated from ICOT with her master's in 2017, and she was the first student to double major in aging studies with a pre-OT degree of occupational science. She completed her clinicals at Temple, Shepherd Pratt, Johns Hopkins, and Northwell affiliate. And after graduating, she moved to Atlanta, where she worked at Atlanta Medical Center Level 1 Trauma Center, the Emory University Hospital in their cardiac and neuroscience ICUs, and the Shepherd Center. At the Shepherd Center, she transitioned through the continuum of care for individuals that sustained brain injury and spinal cord injury. As an OT, she has a passion for working with individuals that acquire spinal cord injury by assisting them to return to all aspects of living a fulfilling life, such as triathlons, having a baby, or skydiving. She's also acquired 5,000 hours of casting and splinting for neurological disorders of upper extremity and belonged to the Georgia, South Carolina, and Texas Hand Therapy Association. In 2021, she moved to London to reestablish their spinal cord injury program post-COVID in a private hospital. She also belongs to the Royal College of Occupational Therapy and Neurological Practice. In regards to research, she assists Brunel University Master's OT students with their theses, most recent being the effects of quality of life in LGBTQ+ population post-spinal cord injury by Curran Brown. She's so excited to speak with you all about how IC has prepared her to be a successful clinician. And personally, after hearing all of that, I cannot wait to hear all of the stories she has. So she'll start us off with an overview of her work and experiences, and then we'll have a question and answer period where you can all chat directly with Rachel. But without further ado, I'll turn it over to you, Rachel, to get us started.
Hi, Emma. Thank you so much for that introduction, and it's such a privilege to be here today. I was wondering if you could also share the PowerPoint on the screen, because I worked during COVID, so technology not so good, sharing simultaneously and stuff, if you don't mind. sharing the presentation. So yeah, that mouthful of work experience. I would not be here today if it was not for Ithaca College. And so I've prepared a slide specifically discussing like the treatment interventions post spinal cord injury to achieve intimacy. And then I'll go through all of that. And then afterwards, I'll talk more about like Ithaca College and how it's prepared me for this life living in like 3 different countries, speaking to you from Switzerland. Is the screen shared by chance? I'm sorry.
Yes, it is.
Okay, perfect. Okay, yes, you could go to the next slide. Okay, yeah, so we're going to go through the role of OT specifically for this topic of intimacy, discussing the framework, assessments, and then interventions. So then we could go to the next slide. Okay, so what is the role of OT in intimacy, right? So if we look at someone that sustained a spinal cord injury, most of the time they do identify as men, and the average age is 18 to 30 years old. There are higher rates of paraplegia, so that means they have use of their hands and anything below T4. So if you've taken your neuroscience class with Mindy, you'll know that is below the nipple line. So usually they won't have full innervation of their abs or their legs, but again, it just depends. And so if we look at the framework to the side, we could examine how, you know, sex and intimacy is part of someone's habits, routines, and roles. And specifically, it's part of social participation, and it is classified as an ADL for insurance purposes. We could go to the next slide. So I really liked this framework, how it looks at the occupational profile and just what, you know, your patient, the person that you're working with, is doing. And so through the evaluation, and then also what I love about this is how it's a collaborative process, right? Like as a clinician, you're not just coming to your patient saying like, okay, this is what we're going to do today. It should be, you know, client-centered. It should be what that person wants to work on, because then they're most engaged, and then you're helping them return to something that's more meaningful to them. And so I like the arrows in this because you're constantly going back to like, okay, what are the outcomes of this evaluation and what are the interventions we need to work on? And it's not just like linear process, you know, it's circular. You need to keep collaborating, keep problem solving and working together to like help your patient and or like client, whoever you're working with, whether it be in an inpatient or an outpatient setting, return to what they want. The next slide, please. Specifically for assessments in spinal cord injury, you begin with the ASIA scoring assessment. And so that is a standardized assessment that looks at the sensation and motor impairments that someone may have sustained after they've had a spinal cord injury. Specifically for incomplete injuries, the erogenous zone will change. So I'll discuss more what that will entail after. And then there's also an assessment that is a questionnaire. And so it specifies someone's comfort, their feelings and perceptions regarding sex. So maybe if you don't have that open dialogue with your patient where, you know, they're not going to exactly tell you like, hey, I'm feeling super uncomfortable with sex, but you still have that rapport, you could give them this questionnaire and it targets that on a scale of 1 through 5. And it's also standardized so that for insurance purposes and documentation purposes, at the beginning of your treatment, you could have that. And then as you're performing your treatment sessions and upon their discharge, you could reevaluate that as a discharge outcome to see how they feel now about sex and intimacy. Of course, you always want to be mindful of any type of cultural implications. For example, in London, I was working with a lot of patients that were from the Middle East. So I had a 19-year-old patient who was from Kuwait, and it would be absolutely unacceptable for me to talk to him about intimacy, right? And so I tried to hand it off, unfortunately, to like the male nurses, because that's what I was told culturally, that's what needed to be a part of their practice. And it was still because they were like conservative Muslim. No, this was not going to be discussed. So even though we always have the best intentions of OTs, we never want to judge our patients, and we need to be respectful of their practices and beliefs. That being said, it's really important to build this patient rapport before you go in and talk about this topic, right? You want to treat your ADLs, especially in an inpatient setting. So you're working on upper body dressing, lower body dressing, showering, bladder and bowel management. And then when I was working at Shepherd Center, it was really cool. They had peer supporters, specifically Corinne Brown, where I just assisted her with her master's research project. She has been paralyzed since she was 6. She has an L1 spinal cord injury, and I just think it's really meaningful for people that have sustained a spinal cord injury to see someone else later on post spinal cord injury living a fulfilling and meaningful life. You know, it just means a lot more when they could see it from someone who's actually doing it. And then also, you know, having that safe space, right? There's going to be patients where maybe you don't feel comfortable talking to them about this, and you could work with your medical team and work together to see, okay, what is the best way to tackle this as a team? We could go to the next slide. Thank you, Emma. Okay, so these are just pictures of the Asia assessment on the left, and then this is just a screenshot of the sex quality life assessment. It is not for free. You have to be a practitioner, so that's why I couldn't post the whole thing. Sorry, guys. We could go to the next slide. Okay, sorry for, I have a Spanish keyboard, so this is Redefining Sex. So it is a multidisciplinary approach. And you also want to incorporate the partner, right? This like, so if they don't have a partner, we'll get to that, but you want to have their partner included, because a lot of times these patients are either married, they're engaged, or they have a long-term, you know, boyfriend, girlfriend, or someone that they've been living with. So you want to include them in that, because they have this idea of what their life was going to look like, and their life will still look like that, but you know, you're going to have to make modifications and adaptations, and you want to include that person. At Shepherd Center, we had a neuropsychologist, so really collaborating closely with the psychologist, because it is a team approach. Don't feel like you need to take this on as yourself. That's like the beauty of allied health. You know, you have your speech pathologist, you have your physical therapist, you have a whole team around you. So collaborating with your colleagues to decide, you know, who is going to tackle which component. Also, after a spinal cord injury, people have a decreased sense of self-esteem, and there's a lot of stigma with the injury as well. You know, they may not feel like themselves. So working on things through that, working on things like self-exploration and body positivity. And then there's also different forms of sex where it's not all just about achieving the orgasm. Specifically for tantra sex, it's about, you know, experiencing that pleasure with that person in a spiritual way. So it doesn't need to be physical. And this is really great for people that have sustained a cervical level of injury, where maybe they cannot move their arms and their legs independently, and they don't want to have their partner move it during being intimate. So examining things like that and giving your patient the tools where they could do that on their own, and also showing them like, okay, there are different forms of being intimate, and it doesn't just have to be physical. We could go to the next slide. Okay. Of course, there's a lot of barriers with this. Specifically, it's a very taboo topic, you know, like, even though oftentimes occupational therapists in hospitals are usually the ones to tell patients, even after, you know, open heart surgery, like, hey, if you can't walk up the stairs without getting out of breath, then you can't have sex because your stitches aren't healed. Or if you've just had a hip replacement, you can't move past 90 degrees. If you have sex, you're going to pop out your stitches. You're going to have to come back to the hospital. So it's always kind of been part of a role, but especially for people that sustain a spinal cord injury, it's a little more intensive, specifically with the bowel, bladder, skin integrity. And so just keep that in mind when you're doing that. Like if it's not something you're comfortable with, then maybe working with the psychologist, or maybe, you know, this is not an area you're ever going to work in, and that's okay. That's like the beauty of occupational therapy. There's so many different areas where we could work. Especially for women, people that identify as women, they are not as represented in the spinal cord injury community. And they're often very fetishized when they are in a wheelchair. So creating a space where they feel safe, not only in the hospital, but then afterwards, like establishing tools where they have support systems around them if they are experiencing that. We could go to the next slide. Okay, the fun part, the treatment interventions. So primarily, I would always work with positioning. And so you do like an activity analysis breakdown. And so specifically for someone that has paraplegia, you're working getting into quadruped. So before even doing that, you're working in getting in prone and then positioning their legs. And then can they get up onto all fours, right? And then from there, you grade it up to tall kneel, and then you have usually, I call it a wheel. It's not a wheel. It's like a big, expensive piece of plastic. So someone pulling themselves up onto that, and so they could replicate different positions. If they don't have the strength for that, that's fine. And then you're working on advocating for assistance with positioning. Again, co-treatments with the neuropsychologist will be key for them and for you. You never want to put yourself in a position that's going to be uncomfortable for either of you, especially regarding this topic. You always want to have, you know, another colleague with you as well as their partner. And then you also want to work on like increasing their confidence. You know, if they have a colostomy and a stoma bag, there are different coverings for that. There are different ways that you could hide the scent of the stool. So either putting laundry detergent in, scented laundry detergent, you could put like scents of fragrance in. And so people don't feel as insecure with the stoma bag if they no longer have like full sensation of their bowel. And then just overall education, right? So we could go to the next slide. Okay, bladder and bowel. So you may be wondering like, whoa, this is not what I signed up for as an occupational therapist. And depending on the setting you're working with, maybe that's not what you're ever going to work in. But specifically for patients that have sustained a spinal cord injury, bladder and bowel management do fall under the role of OT, especially managing, you know, how they're going to catheterize themselves, what type of equipment they're going to use for their bowel program because they no longer have full sensation or their sphincter is impaired. And so definitely reviewing autonomic dysreflexia. And so that is when the diastolic blood pressure number becomes too high and then someone is at risk for having a stroke. And so how to manage that is usually there's like a blockage in the bladder or the bowel, or they're feeling pain where they no longer have sensation. And so it's kind of like a fast guessing game. And you want to prevent that, especially when you're being intimate. Also, you want to tell your patients like, hey, you need to just like you pee, you know, afterwards when you have sex, when you had full sensation, you want to do the same thing with your bladder program. You want to catheterize 2 hours before and then immediately after so you don't get a UTI. Bowel programs for patients have to be very regimented. So they either happen in the morning or at night. So you want to be intimate 2 hours before you have your bowel program, or else if you're moving too much stuff around, then you might have an accident. And so I was talking to a former patient the other day. I was like, what is something you wish I had told you when we were going over this. And she's like, how often I PM myself? And I was like, okay, all right, that's good to know. And so also giving patients the tools that they need, that after they're done, with inpatient services, that they could continue, like if they're having like infrequent bladder accidents, that they could go to like pelvic OT or PT to help manage that. And then also it could be because of spasms or neuropathic pain, but just giving your patients the tools that is discussed in the next slide. You could go, thank you, Emma, for clicking away. And so it's in medication management. I'll circle back to that. And so also as part of the bladder and bowel management, skin integrity in the spinal cord injury population is huge. You want to prevent any type of pressure ulcers. And so any type of bony prominences, so your knees, ankles, hips, and then padding and positioning is also really important. So, we never judge as OTs, but to tell people not the floor, not the hard carpet, because you're going to get a skin ulcer. Like this is just a nice padded surface. Next slide. Okay, and back to what I was talking about before, there's different medication management. So if a patient is having bladder accidents, you could have Botox injections in the bladder to mitigate the accidents. And then you also work closely with the urologist, right? You'll be trying different things, and then you'll go to your urologist. The patient will go to the urologist to try different medication. For patients that identify as male, there's Viagra and different versions of Viagra. And if someone doesn't want to take that, there's injections that they could take right before they want to get intimate to promote an erection. And then also if someone is having really painful spasms that's preventing them from being intimate, there's gabapentin for neuropathic pain. And again, I always tell people like, hey, I'm not the medication lady, but you work with your team, and it's important to know what these medications are, so you could help educate your patient and you're like supporting your team. Next slide. Okay, equipment. There's not a lot of pictures on this slide for lots of reasons. Wanted to keep it kind of PG. So there's a penis pump. It's exactly what it sounds like. And so if someone is afraid of the injections, they don't want to take medication, there is an option where you could like pump it up. It does exactly what it describes, specifically for women that want to explore more solo activities. They have different vibrators that are hands-free. And as the OT, I have adapted the buttons. I've built up the buttons so that if someone has impaired dexterity, they could just like tap it with the wrist. I have made handles out of splinting materials where they could just go on and then hit it and then do what they got to do. They also have mirrors with a clip on it. So if someone is using a hospital bed or a bed with railings at home, they could position it so they could see everything. So again, this is the more physical components of sex, but then also things that we could do as occupational therapists. The next slide. Okay, documentation. You may be wondering, how am I going to write about this? How am I going to bill for this when I go on my clinical? So here's a SOAP note that is not from a patient. So definitely write more in your SOAP notes. For HIPAA purposes, I didn't want to copy and paste. I usually do, like if it's a 60-minute session, it's billed as an activity of daily living. Or if we're doing a lot of positioning, it could be therapeutic exercise or therapeutic activity, and you just want to be objective with what you're doing and provide specific examples, a quote, make sure that you're getting consent. We could go to the next slide. Okay, here are some pictures of equipment. And so there is this website called the Intimate Rider website. And so they have all different things. I know the picture to the left is a little racy. So they have a bench for someone that has paraplegia, and it moves, it rocks back and forth. and so their partner can just go on top. They also have the bench to the right, that, you know, men or women, or however you identify, can use. And then they also have different pillows to just help assist so that your partner doesn't necessarily have to carry you. If you are having sex with someone that is able-bodied, and so that it creates more comfort in between the two of you, and then also just the padding and positioning for skin integrity, like I discussed before. And then if you're going on a fun Airbnb trip, you could all carry that in that fun little sack and be discreet about it. We could go to the next slide. Okay, this is my friend Karen Brown. Her research is really great because it focused on women that don't identify to be a part of a heterosexual relationship, which I think is really important because, you know, you're taking two marginalized groups. And so specifically women in the spinal cord injury community aren't always represented. And also there's not a lot of tools out there for people that don't identify as straight. And so she did her master's thesis on this at Burnell, and basically find there's an occupational deprivation, and we need to do more research, and it's part of the occupational therapist role. And then there's other current research at Greg regarding sexual function. Me and my team, in the middle of COVID, we're supposed to start a project with the University of Sydney regarding this, but because of restrictions, lockdowns, and yada yada, you know, COVID times, unfortunately, it wasn't able to come to fruition, but hopefully one day soon it will happen. And then you can go to the next slide. Ithaca, woo, circle back. I don't know if Amy Gurney is still there. She was an angel, the nicest woman. She adopted like 5 different children. She taught most of like the psychology and pharmacology classes. And at least once a lecture, she would say, don't have sex with your patients. So just because you're talking about sex, keep your professional boundaries. Especially for this, protect your medical license. You know, it was expensive to obtain. So never put yourself in a situation where you're uncomfortable or they're uncomfortable. Loved going to Ithaca because it taught me to have like a really open mind and be really flexible. And especially because I had like the dual degree in aging studies, even though at one point I was working on like a team just for teenagers. It provided a lot of opportunities, especially when I moved to Atlanta, where there wasn't a big network of IC alum. It got my foot in the door. And Ithaca really taught me, don't chase money, chase the experience that you want. So it was really important for me that I wanted to work in a hospital. So I took a very low paying job in the beginning. Like I think I was making $20 less an hour than my peers, just because I wanted to have that trauma experience on my resume at Atlanta Medical Center. And it wasn't the most beautiful, glamorous hospital. Like if you compare Emory University Hospital to Atlanta Medical Center, they're night and day. But if I didn't take that job at that hospital, I wouldn't have gotten to Emory and to Shepherd Center. And so it might not always be really glamorous, but you know, think of your long-term goals and how you want to achieve that. And I will say at Shepherd Center, there are a handful of Ithaca alum. I have no idea how we went like 1,000 miles down south when none of us are from there. We're all from like New York or Jersey. But you know, there's still managers there. So it's really great. Like if you want to work in the spinal cord injury world, especially because of Mindy and Mindy's experiences, she really like sets you up with the tools to do so. Also love casting because of Mindy. We had like an 8 a.m. lecture and she was like, okay, you're gonna like make a cast and saw it off. And I remember being horrified because it was like my roommate of 5 years. And I was like, oh, I'm sorry, Nikki. And then I like, 5,000 hours of that. So if it wasn't for that experience, like, I don't think I would have gone down that path. And I'm really grateful for that, because a lot of other OT schools don't emphasize neuro the same way Mindy does, or they're not going to like make you cast your roommate at 8 a.m. in the morning, like that. Valuable Ithaca experience. And then I would also say, just, I didn't study abroad at Ithaca, but I always wanted to. And Ithaca is a diverse place, it's really open-minded. And that gave me the tools to then live in the United Kingdom, and then Spain. It's a whole long story of how I've gotten here, but if I didn't have those experiences at Ithaca College, I probably wouldn't be living or working abroad now. And that to me is like priceless, like I really love my life, how I could help people, and then also like travel to a different country once a month because I'm in Europe and stuff, just as like a personal note. And then I think there's a list of citations next. That's the summary. I've said all of that. That's fine. There you go. Citations. And then, just my email at the end. Ginger Chimes is a manager, and they're expanding at the Shepherd Center. So if you want to work in the spinal cord injury world, or if you're looking for field work, email me and I'll send you your CV and resume to Ginger Chimes as well, because they're hiring right now. But thank you so much. I know I went rogue from what the questions were supposed to be.
No, that was great. Thank you so much, Rachel, and for speaking so candidly about, as you said, a topic that's so often stigmatized or considered taboo. So thank you so much. That was so valuable. I already see Mindy raising her hand.
I just want to say, every single time I'm just blown away. I'm just blown away and just so honored and proud to have worked with all of you amazing practitioners. Thank you, Rachel, for sharing your experience. Really.
No, thank you so much, Mindy. Like,
it blows me away. Thank you.
Yeah, so if anyone has any other comments or any questions, this is our time. So again, feel free to use the chat, unmute yourself. If you don't feel comfortable sharing or speaking out loud, you can also always private message any of the hosts and we will get that to Rachel as well. So if anyone has any questions, feel free to share.
this is a safe place. You could ask me anything.
Mindy, do you have a question?
Nothing bad. Don't get nervous. I was just wondering if, I know you talked about having great mentors and training where you work. Did you get any additional continuing education? Because it's such a niche area. I'm just wondering if there was any courses or anything additional you took.
No, unfortunately, there's not really a lot of education specifically for occupational therapists. So we're trying to like establish our own, because it is so niche. And it's only offered for psychologists. And so then the hospital wouldn't pay for it because we're not able to get credits for it. And so it doesn't go to our license and stuff. But I know it's something we're working on.
I have a question about how, just like your journey and how you ended up abroad. I know you touched on it a little bit, but just curious about that.
Yeah. So how I ended up abroad. So during COVID got spicy. And so I started looking at my medical license to go to New Zealand because it's like, you know what, I want to be outside, I'm going to live in a van, and I'm going to be a hand therapist. That's what I'm going to do, because there was just like love working at Shepherd Center. There was just a lot going on in Atlanta, and just like being in the city, I like just was craving outside time. So I found a job in New Zealand. I got my work visa, I got my OT license there, and they would not let me in. But they weren't letting anyone in. And if you left as a citizen, you had to sign your like rights away, that regardless of what was happening for like the Australasia, like Australia, New Zealand, you were not allowed back in. So then my manager at Shepherd, she had worked in London, and I was up for like a managerial role at Shepherd, but Shepherd, they want you to work for a very, very, very long time there. And I didn't have any family there. And I knew I didn't want to live there forever. It had nothing to do with Shepherd. Love working at Shepherd. That's why I stayed in Atlanta as long as I did. But I really missed traveling. Like why I went abroad was all personal reasons. So then I started applying to positions for the NHS, and I got a role as a stroke manager. And then I was recruited by the private hospital that I worked at to like rebuild their spinal cord injury program at the Wellington and stuff. But it's takes a very long time to get your medical license in the UK. It could take up to a year just because everything is by paper, and there's so many holidays, there's so much time off. So it just takes a really long time. For example, my fridge was broken in Barcelona. It took 2.5 weeks before a new one was delivered. Like that would never happen in the States. You know, it's just like time is slower, but that's, you like pick and choose your battles. I don't know if that really answered the question, but I am like happy to send you the information. It's called the HCPC for the UK. Australia has a different one where you have to send in videos, and it also takes a year. The UK is just paper, and I would do it as soon as you graduate, because once you start working and you have like all of the different things on your resume, it's a lot of paperwork. Like just do it right away. There's not a test. You just have to prove you have your like degree, and it's just a bachelor's to practice there, and so you'd already be overqualified and stuff. It's the paperwork that takes a very long time. Everything is paper.
I have
Does
a
anyone-
question.
Yeah.
So you touched a little bit on like cultural sensitivities when working with sex and intimacy, and then also sort of like the billing aspect. And so I was just wondering if you found it like easier or more difficult working with sex and intimacy under different like international insurance programs that are different than the US healthcare system, but then also like cultural considerations and how you navigate that when you yourself are adjusting to a new culture, how you would navigate that with a client.
Yeah, that's a great question. So specifically in the Atlanta, because it is the Bible Belt, so there was a lot of patients that they waited until marriage to be intimate. They would be married for like 3 to 6 months and then be paralyzed, and they were distraught. And so that was also another like cultural implication, which is I'm not sure where you're from. I'm from New York. There's just like a difference between like different parts of like, Georgia, Tennessee, South Carolina, compared to some states up north. And so being considerate of that, but then also when I did work in London, most of my patients were from the Middle East. They were from Qatar, Kuwait, Saudi. And so always being, and then some people aren't actively practicing in the Muslim religion, and some people are very conservative with their practices. And so again, building that rapport, like you're never going to go into like someone's room that you just met, and like, I'm going to talk about sex today. Yeah, that's what we're going to do. That's you're never going to do that. Please don't do that from this presentation. But, you know, it's important to really do the occupational profile of your patient before you even bring in this component, and just learning as much as you can about someone else's culture, to be respectful and to just like help them in what their goals are, because I find it's really significant to really understand like what drives that person to motivate them and stuff. And you can't really do that if you don't understand all of those layers, especially, you know, that was very different for me, because at Shepherd, I was part of an international team. So a lot of my patients pre-COVID were coming from different parts of Central, South America, and then the Caribbean islands and stuff, and then all over the United States. And then with COVID, then we were only taking them within the South, depending on what was happening in the world, as well. Like when there was like the crisis in Haiti, we started like taking patients from Haiti. And so I think I've always had, because there was always different, someone coming from a different country, I always had to be considerate that, okay, now I need to learn like this different culture. And I think that also like goes back to Ithaca College is like such an open-minded place, you know. And then when I moved from Ithaca to Atlanta, I was like, oh wow, Ithaca is like this beautiful magical bubble, and I would like to go back there. But I think it's, you know, it gave me the skill set that I've always been able to carry with me.
Thank you. We have a couple more minutes too, if anybody has any questions coming up for them.
I have a question, Rachel, based on your ICOT education and, you know, all of the settings and places, geographic locations that you've been, and particularly on this topic of sex and intimacy with folks with spinal cord injury, what is one thing or one of the things that you wish that you had known or learned or been exposed to support your ability to kind of engage with this population and do this important work?
That's a great question. Thank you. Like I said before, Mindy was like really key in my love of like neuroscience, but I think just going on the clinicals, and then when my, like different friends would go on clinicals and we'd be like, oh, what did you do today? And it's like, oh, I told this patient they can't have sex. And we're like, oh, I don't know if anyone ever told us, you know? So I just think just like maybe a class devoted to that. And I think you guys do have a class now, and it's become like a more accepted topic, you know, like I would say probably within like the 2012 to 2014 range, it was still like, ooh, hush, hush, we shouldn't really like be saying this out loud, you know, you got to make sure like, look who's around, and stuff. But now I think we could talk about it more freely because, you know, it's in the scope as an ADL as well. And so I think just like even having just like sessions with like having someone pretend they're the patient and then someone like being the OT and just like facilitating that conversation and then like providing feedback to one another. I think that could be helpful as well, because like you, especially going in as a new grad and now you're like having these conversations with people, it gets easier over time and stuff, but I know there were still like colleagues I work with, they'd be like, oh, I'm never ever gonna do that. I'm like, okay, that's fine, you know. And I think it's just, again, depends on like your comfort level as well. I'm not sure if I answered the question. I'm sorry.
You did, thank you.
We have time for about one more question, if anything is coming to anyone. If not, I have one more. I was just wondering for anybody that this might be on their mind and they want to integrate working on sex and intimacy more into their practice, regardless of setting, but just aren't really sure where to start or where to find their footing. Like, what's one piece of advice you would give to somebody that knows that this is important, but might not feel that comfortable with it themselves yet to work on it with their clients?
I would look at the literature and, you know, specifically with the population you're working with, because I think having data-driven research is really helpful in facilitating that conversation, because you have scientific evidence to back it up as to why it's important. There's also, I unfortunately, because of the Wi-Fi here, I had some videos initially uploaded, but they weren't playing. Just like even YouTube, I think, and just looking at like someone that has a specific diagnosis that you're working with, and, you know, and sex and their dating stories and stuff, or just like their day-to-day struggles on YouTube and just going from there, or like trying to find someone like maybe a friend that may have this specific diagnosis, and that you feel comfortable enough talking about it. But definitely looking at like different support groups. And I really think like YouTube is great for videos as well.
That's great. Thank you so much. And I'm sure that makes a lot of people happy to hear being evidence-based and going back to the literature and not being scared of research. Definitely, definitely helpful and encouraging to students that might be intimidating too. So thank you so much. And thank you again, Rachel, for being here, especially with the time change. I know this is not easy for you, so we so appreciate it. And as a reminder to everybody that this video and transcript will be provided on YouTube in the coming weeks. So if anyone has any questions or wants to reference it, please feel free to watch that. If you have any questions that come up for you after the session, also feel free to email anybody on the planning committee and we can get you in contact with whoever you need to be. As a reminder, our next speaker series session will be on March 22nd with Nikki Reedy on family coaching and neurodiversity. So it'll be a really great conversation. We're really excited for it. And thank you all again so much for being here. We so appreciate it. Sorry for the train in the background. Have a great rest of your nights. Enjoy the warm weather if it's warm where you are.
Thank you, Rachel. Thank you.
Thank you so much.
Thanks, everyone.
Thank
Thank you, Emma. Thank you, Julia. Thank you, Jenna.
you, Mindy.
Oh, thanks.